Thank you very much, sir. Thank you very much for those kind words of introduction about me. But I think I enjoyed myself last week because it was like a complete kind of a revision for myself of anovulation. And friends, we are again meeting because that's what Oosphere team has decided that every Wednesday we will have pure academic session completely and focusing on that topic from A to Z about that topic. And unfortunately, our expert Dr. Kedar could not join, so I took over in his place. But of course, we will love to hear him on the management of male infertility. So today's topic is on evaluation. So today you'll understand one more thing, that how deep this male infertility subject is, because here we are going to discuss almost for 1 hour what is in male infertility. And please feel free, if you want to discuss anything, I can stop anytime because this is interactive session. And please don't hesitate to ask me questions in between. So again, uh, evaluation of male infertility, and this is, I love this slide when it comes to male infertility, that always happens when any married life, that she's always right, that is Mrs. always right, and we have to find out Mr. Right, and that perfectly suits for male infertility. And we know that the male infertility factor, if you talk about percentage of patients, it is increasing and increasing and increasing over decades and decade. And there are lots of factors we are going to touch upon today's presentation, that how this incidence is increasing. I remember when I started my practice, that was at least 2 decades back, we used to always think that male infertility is just 20%. But now, if you look at overall patient, you will see, even if you include combined infertility, unexplained, you will see 50 to 60% is the male infertility patients. And that's what it is, no more as a rare factor. It is, in fact, has become a more common factor. Now, when it comes to evaluation, our expectations from ideal test is it has to have a ability to test all functions of the sperm. So that is one what we expect from that test. Second, it should be able to predict male fertility potential. So not only it diagnoses the problem, but it should help us to project that what potential he will have in in creating a fertility. And the third, it has to have an ability to assess the likelihood of success of ART. So that's another thing. So do we have such tests? So let's see, begin with our semen analysis, which is always the first test we say. Now let's start with the basics, that what are the constituents of semen. So one, we need to understand, one of the important is, the first part is a mucoid secretion of bulbourethral glands, which are known as a Cowper's gland. And these secretions are to lubricate urethra and neutralize any residual acidic urine. So that one is the first portion of, usually the first constituent of semen. Second comes is the acidic secretions from prostate. And you have to understand, when it says acidic secretion, so they allow to have acidic pH of the semen sample, and that's why it is important. So what it contains, because of what acid it has, it can give acidic pHs. It contains zinc, it contains citric acid, it contains acid phosphatase, and it also contains prostatic specific antigen. So these four contents are actually the part of the prostatic secretion. Next is the secretions from chorda epididymis and the vas deferens, and that actually contains spermatozoa coming from the testes. And fourth part is a seminal fluid, that is seminal plasma, which is coming from seminal vesicle, and usually it is alkaline secretion. So it maintains alkaline pH of the semen, and that's why it contains it. It is because of it contains fructose, it contains prostaglandins, and it contains seminogelin proteins. So if you remember, in semen, there used to be always on, it is always there that fructose present or absent. So it is that presence of fructose and absence of fructose is related to the seminal vesicles. So if there is a obstruction at the ejaculatory duct, then you will not see seminal vesicle secretions coming into role. And that's what we see fructose absent. I just thought of to touch upon at the right time when we are discussing it. So when you see fructose negative, there is a high likely that there is a obstruction of the ejaculatory duct. And because there are no more kind of secretions from seminal vesicles because of obstruction, and that's why we see acidic pH more and absence fructose into this kind of obstructions. Let's proceed with the next. And what are the prerequisites for semen analysis? So we need to have at least 2 to 5 days is essential. Now, what is exact and accurate? So I will say minimum 3 to maximum 4 days. Beyond that, there is a little higher chance of false positives, higher sperm DNA fragmentation, and you may have false positive result because of prolonged abstinence. So it is better you specifically tell the patient that follow 3 or 4 days of abstinence before the semen analysis. So that is very important that you explain them that you whenever you plan analysis, first you ejaculate, then don't ejaculate for 4 days, and fifth day you visit to the clinic. So that's how he or she, the couple can plan a visit for semen collection. Now, what happens with prolonged abstinence? If it is like a 10 days, 2 weeks, even couple comes with abstinence of 1 month. So there is accumulation of more number of morphologically abnormal spermatozoa. So prolonged abstinence is something which is not good in terms of sperm morphology. When you have a shorter abstinence, then quantitatively less volume of the semen and reduced number of spermatozoa per ejaculate. So sometimes patient has ejaculated yesterday and they come for analysis today. So that's again the amount of seminal plasma is going to be less. Number of spermatozoa per ejaculate is going to be less. So it is very important that we don't want shorter or prolonged abstinence. Adequate abstinence, which of 3 or 4 days is best. So your counseling matters a lot. What are the methods of semen sample collection? So there are, both the ways they can collect it. Like husband can masturbate and collect whole semen in a wide mouth container, and it helps to avoid contamination. What is withdrawal method? Where a couple keeps a relation in a semen collection room, but just before ejaculation, he withdraws the penis and ejaculate into the container. Now, only problems here may be that sometimes we may lose some volume of the semen because of sudden ejaculation, or sometimes there is a contamination. And medico legally also it is suggested that you request a husband and a couple to come to the center and collect the semen because of the identity issues. So the biggest advantage is that you know the exact time of collection, you know exact time of liquefaction, so you can calculate liquefaction time. Okay, so collection at home is acceptable only if it is delivered in 45 minutes. But as far as possible, medical legal point of view, that is very important that you ask the patient to come and visit. And that is why having a very good semen collection room, like a private bedroom, it has to be there, where a patient or a couple even feel like keeping relations just for a semen collection. So that is very important part for the semen collection. Now, sometimes you have seen the reports of semen analysis, but you are going to evaluate it again. So at that time, when you look into the previous reports, it is mentioned as hyperviscous. So your prolonged liquefaction time. So we need to understand that this patient do have a absence of or deficiency of certain enzymes, which is not allowing this coagulum or a coagulated cement to liquefy. And that is why it is important that you add a sperm washing media. The advantage is that of adding media is a interval between collection and evaluation may be extended to 2 3 hours. So because it's a media which is allows sperm viability, so even if your evaluation interval from collection is more than expected time, it's all right. This media will not allow sperm to lose its viability. Okay, but it is very important that the liquefaction problem. So as soon as the ejaculation happens in a container having sperm washing media, it doesn't form a coagulum, and that will help us to assess it very properly. Now, what can be the material of container? So polypropylene, but not a glass jar or a polystyrene container, which is associated with increased risk of viscosity and viral infections. So simple polypropylene is the enough to have as a part of container. Now, when you physically examine a container having semen sample, you look for coagulation. So it is the coagulation first is due to protein kinase enzyme. Now this is secreted by seminal vesicles, seminogelin proteins. So protein kinase, you remember, the coagulation happens because of the seminal vesicle protein kinase enzyme. Now it is usually like immediately after ejaculation. But if you don't see this ejaculation, means there was no coagulum at all, directly it was liquefied semen, then there is a possibility that there is the absence of seminal vesicles because there is no protein kinase, and vas deferens also there is a high. So absence of coagulation should immediately alarm that something wrong with the seminal vesicles or vas deferens. Next is absence of coagulation associated with absence of fructose in seminal plasma. So again, as I said, fructose is an important content of seminal vesicles. So if there is an absence of coagulation, look for the fructose. And even if the fructose is absent, high likely that seminal vesicle agenesis or, probably it is a blockage at the ejaculatory duct. Now about liquefaction. Now the liquefaction after the coagulation, it is caused by the proteolytic enzyme called fibrinolysin, fibrinogenase, and aminopeptidase. Now these are secreted by prostate. So remember the sequence. First, semen comes out as a coagulum, which is regulated by seminal vesicle. Then it liquefies, which is regulated by prostate. We may not remember these enzymes' name. Now, normally, it just takes 15, 20, max to max 30 minutes for liquefaction. But if there is a period which is longer than 30 minutes for liquefaction, which is something which is not good, that is something is wrong, there is a problem with the prostatic enzymes. Delayed liquefaction, or there is something called non-liquefaction, that you have waited for 1 hour but still it didn't liquefy. That is a sign of a severe abnormal prostate function, and there is high likely of prostatitis, and there is no such proteolytic enzymes present in the seminal plasma, and that's why the prolonged liquefaction or hyperviscosity, what we say, is seen. So simple important findings, and it will help us. Now, viscosity is semen achieves viscous state, and increased viscosity always tells you that there is an abnormal prostatic function, or it is due to the infections in the genital tract, and most likely prostatitis or seminal vesiculitis is something what we have to look for. So whenever you see hyperviscosity, because it is most common is infection, treat such husbands with antibiotics first, so that next time when we collect their semen, we want the infection to be treated, so that we want these organs to secrete enzymes properly, so that we get adequate coagulum as well as sufficient liquefaction time or within range. So antibiotic is first thing we need to remember. Now a physical examination. Second part is volume after the coagulation. So volume, normally normal volume is considered as 1.5 to 5 ml. So there is something called as aspermia. So absolutely no semen at all after the orgasm is called aspermia. Generally, you will see this in a retrograde ejaculation, okay, where you don't see at all any semen. But when you see a small volume like 0.2 ml, 0.3 ml, or 0.5 or even 1 ml, it is called hypospermia. Now, the cause is simple. The volume is coming from a major part from ejaculatory duct, and because the seminal vesicles secrete seminal fluid or seminal plasma. So it is important that there is a high possibility of, there is a congenital absence of vas deferens is one possibility, or there is a loss during the collection, which can be just a collection fault, okay, or there is an androgen deficiency, or partial retrograde ejaculation due to obstruction by infection or mucus plug, or even too short abstinence period, which may happen sometimes. Patient do not give that history of ejaculation within last 48 hours, but you can try and generate that history also, very important. Now, hyperspermia, where you see volume more than 5 ml, we have seen not so commonly, but we have seen a man ejaculating 8 ml of 9 ml of semen volume. And usually, rarely it can happen with prolonged period of abstinence, but generally it is the accessory sex glands secretions, over secretions or overproduction of secretions from accessory sex glands is which causes hyperspermia, which is not a problem, by the way, even if it is more volume. Now, Next factor in physical evaluation is a pH. So the normal pH, which is considered perfect pH, is between 7.2 to 7.8. So if the pH is above 8, which is an elevated pH, indicates that there is an acute infection. There is a possibility of acute infection. And three things we have to think of. One is the prostatitis, second is vesiculitis, third is a bilateral epididymitis, so infections. Now, if you have a low pH that is more on the acidic side, so obviously the acidic secretions are absent. So there might be obstruction of ejaculatory duct. So you look for low pH, and if you have a azoospermia along with low pH, it gives you idea that there is a high possibility of congenital absence of bilateral vas deferens. So low pH is, you have to look for even presence of sperms, and it tells you that there is a possibility of CAB-VD. Okay. Now color. Color is a little non-specific thing, but yes, you can take a help of, like, if it is yellowish, there is a possibility of prolonged abstinence, presence of plenty of pus cells, pyospermia, that is infection, or maybe jaundice. If it is reddish and brownish, it is possibly some bleeding which has contaminated the semen, and it might be because of injury during collection or any pathology in the male reproductive tract. Third, if it is completely watery, there is no color, transparent. So that is because of the less cellular contents, means it contains very low number of sperms or white blood cells or macrophages or plasma cells. And this is generally you will see in azoospermia because there are no sperms, and that's what it appears completely clear. Now coming to the next physical parameter. What happened? It's not moving. Okay. Yeah. Let me see. Yes. So next slide is biochemical analysis. Now you may check for zinc and acid phosphatase levels, which is like a lower reference limit is more than 2.4 micromole per ejaculate. But again, it is decreased in chronic prostatitis because prostatic secretions contains zinc and acid phosphatase. So that also you can test. You can test in biochemical way and find out if he has a chronic prostatitis. Again, absence of fructose, as I said, congenital absence of vas deferens is one possibility, or obstruction of the ejaculatory duct because the source of the fructose is seminal vesicles. A glucosidase, which is again reduced in chronic epididymitis, this is the cutoff. But generally, in routine lab semen analysis, other than fructose, you don't see zinc acid phosphatase levels and glucosidase. So what do you need for semen analysis, which is the best, is the macular chamber. And I will always say that is the best chamber. Now, why I'm saying that, if you look into this diagram, so the moment you take a drop on the macular chamber and you put this cover slide, the column of the fluid of the seminal plasma, which is created below the slide, it has got a depth of 10 microliter. So it has got a uniform fluid column, which is very helpful for uniformity and perfect or accurate sperm counting, counting of the sperm, or as well as assessment of motility. So it gives you very precise calibration. No dilution gradient is involved, and count calculation is very, very easy. How do you do that? It's very simple. The cover slip has got hundreds of squares on it marked. So when you assess from into 10 squares. So you may start from left, you may start from right, you may start from up, you may start from below, but check the number of sperms seen from 1 square to 10 square, and that exactly equal to is million. Whatever value comes is a million per ml sperm count. So probably I feel that it is the very quickest way to assess sperm count, and that's why macular chamber is the most important thing. So as per the recent guidelines or WHO manual, which is now they have come up with 3 or 4 manuals, but I think still 2010 manual we follow, and which says that 32% should be your progressive motile sperms. Okay, that's very important. There is something called as a total motility, that is total motile sperms, and that also includes grade 2, that is non-progressive motile sperm. So in terms of assessment of motility, this is very important that grade 4 plus grade 3 should be at least 32%. In my practice, I still follow grade 4 1999 manual because that gives me more accuracy. So the grade 4 percentage has to be above 25%. But we have seen this, though it is mentioned here that grade 4 is rapid progressive, that is linear progressive, which is having 25 micrometer per second speed. Grade 3 has got 5 to 25 micrometer per second. Grade 2 is a non-progressive motile sperms, and third is a absence of motility. Though we cannot calculate their speed, so generally what I suggest is you start doing your own sperm assessment or semen analysis. You will be master in it. In like within 30 seconds, you can really count and assess the motility. Third part is the sperm morphology. According to 2010 manual, minimum 4% should show a normal morphology. Anything above 4% normal morphology is normal report in terms of total sperm morphology. So that is very important. And even if you see number of leukocyte less than 1 million per ml, it is normal. If it is more than 1 million, there is a chance that there is a possibility or presence of infection in reproductive tract. So this is how you can compare 99 to 2010. The semen volume cutoff was in previous was 2 ml, now it is 1.5 ml. Total sperm in the ejaculate has to be above 40 million. Now it is 39 million. The sperm per ml, the cutoff has was before that was 20 million. Now it is reduced to 15 million. Progressive motility 1919 was insisting on grade 4 motility, which they according to that manual should be more than 25%, which I personally follow in my practice. In 2010 manual, grade 4 and grade 3 has to be above 32%. Total motility is total motile sperms. That includes all grade 4, grade 3, grade 2. And previous manual said that it has to be above 50%. 2010 manual said it has to be above 40%. And morphologically normal looking sperm, previous manual said 14% and now it is 4%. So there are lots of changes happen with this kind of parameters. Now we know that if the presence of more than 1 million leukocytes per ml in ejaculated semen, which suggests leukocytospermia, and that can be detected by peroxidase test, and it's suggestive of infection. Or you can stain with papanicolaon and you can identify the white blood cells types also, and you can differentiate between an acute and chronic infection according to neutrophil and the lymphocyte concentration. Now, when it comes to definition of oligospermia, it clearly says that the sperm count has to be less than 15 million per ml, at least on 2 occasions done at 2 different times. So many times you see one report which says that there's a 12 million count. Do not jump onto the diagnosis. You ask them to repeat a second semen sample at different time. And if both the semen analysis shows count less than 15 million per ml, you can consider this patient as oligospermic. For your own satisfaction, you may repeat as as many times as you want, but minimum at least 2 reports has to be there. You called mild oligospermia when the count is between 10 to 15 million, moderate between 5 to 10 million, and severe oligospermia when the count is less than 5 million. Now, about low motility, this is just a one quick slide which just gives an idea about asthenospermia, that is low motility. And you may get this asthenospermia in infections, varicocele, higher production of morphologically abnormal sperms, drugs, high DFI of sperms, diabetes, one of the most important cause of asthenospermia in India, and it can be idiopathic. So all sorts of causes. But this is something which I want you to learn today, that whenever you look for semen analysis, when you diagnose male infertility, so when you want to decide what treatment you can offer, that decision of treatment, that is whether IUI or IVF, this decision has to be on total motile sperm count. Let me explain how it is important. So understand one thing, This is, we are talking about grade 4 sperms, which are linear progressive sperms. Now, they are the most important. Why it is important? Because we know that the success of IUI is highest if, or it begins when you have, we are inseminating at least 10 million per ml of grade 4 number of sperms. So that is very important. Now I'll give you simple example. If you have checked on 20 million as a sperm count on a post-wash semen sample, so that macular chamber will give you always 20 million per ml as a post post-wash count. But do we transfer 1 ml of media having these kind of sperms? No, we never. The uterine volume is a 0.5 ml maximum. So when you say 20 million per ml count on macular chamber in post-wash sample, you are actually transferring in 0.5 only 10 million. Are you with me? So your what is seen on the macular chamber, exactly half of it we are actually inseminating. And that's why there is no need to get confused, because certain literature will say that to offer IUI, there has to be 5 million grade 4 sperm into semen. But when it comes to counting chamber, it has to be more than 10 million per ml. And that is what you need to count total motile sperm count in the semen sample. So I'll give you one example as it is written here. A patient has collected 4 ml of semen sample and it contains 10 million of sperms per ml. So in 1 ml, if it is 10 million, in 4 ml, those will be 40 million sperms. So in a ejaculated sample, a person is having total 40 million sperms. Now out of them, 50% are grade 4. So it is clear that we have to calculate 50% of that 40 million, and that comes to 20 million. So we need not do really this calculation that 10 million into 4 million, 4 ml plus 50 divided by 100. No, you can just simply check the volume, check the count, and check the grade 4 percentage motility, and you will immediately understand that how much percentage or how many number of grade 4 sperms I may expect after the wash, after the semen wash. So it clearly says that if you have more than 10 million per ml on counting chamber, or if it is more than only 5 million number, then only you offer IUI treatment. Below this, you probably best is to give IVF or ICSI option. So research has helped us to understand that in 2016, when they studied the effect of this total motile sperm count as a parameter to judge on the spontaneous pregnancy rate and pregnancy after IUI treatment in couples with male factor, how does it help? And they found that if those couples having total motile sperm count less than 5 million, and they were associated with a lower rate of spontaneous pregnancy in comparison with any other values more than 5 million. And that is very important. So that 5 million cutoff or 10 million per ml cutoff is the most important. So whenever you look into the semen factor, once you diagnose male factor as per the semen analysis, you next level of parameter to judge is a total motile sperm count, and this is how you can identify. Third is a azoospermia or cryptozoospermia. Now, azoospermia is a complete absence, so you will not get. But is it that when you have taken a drop and if you don't see any sperm means azoospermia? No. You still need to do one more exercise, that once you take a drop and you have checked all the field of that drop, and if you don't see a single sperm, the next thing is that you take the you do the centrifugation of the tube having semen sample. So let all the cells settle down at the bottom, and you remove the supernatant, and that from bottom, or you don't need to remove the supernatant, you can just put a drop at the bottom of the tube and you aspirate those cellular contents in the precipitate, put it onto the slide and try and see whether you see, because with the centrifugation the sperms are going to settle down at the bottom. And as if there are any few sperms, like which happens in cryptozoospermia, if you happen to see some few sperms, at least you are sure that there is some production is going on and there is no azoospermia. And this sample you can do it for 15 minutes centrifugation at 3000 rpm, and if the pellet reveals no sperm, then you can consider it as a azoospermia. Now, azoospermia can be obstructive or non-obstructive, and generally it is seen, if you understand, in general population, the incidence is only 1%. Okay. So, three types of azoospermia are seen. One is a pre-testicular azoospermia, second is a testicular azoospermia, and third is a post-testicular azoospermia. Just for our own understanding, pre-testicular azoospermia is generally the problem is in the pituitary. Testicular spermatozoa, it's a problem with the testes, and post-testicular azoospermia, there's a problem with the reproductive tract through which sperm transportation happens. So what are the causes of non-obstructive azoospermia? Means there is no obstruction in the reproductive tract, still you see azoospermia. So here you may have hypogonadotropic or hypergonadotropic. So your pituitary might be at fault or your testes might be at fault. So genetic causes, Klinefelter syndrome, Y chromosome microdeletion is something which we should advise here. In patients who may have a history of trauma to the testes or torsion of testes or history of mum infection in the childhood, they may show azoospermia due to severe varicocele. There might be hypospermatogenesis, that is low level of sperm production into the testes. There might be a maturation arrest. So the sperms may not develop any motility and they don't come into the seminal plasma. So that is maturation arrest. Patient may have a Sertoli cell only syndrome, chemotherapy or radiotherapy destroying the testes completely, and drugs like outside exogenous testosterone and anabolic steroids are the few causes of non-obstructive azoospermia. Now, what are the causes of obstructive azoospermia? There is an obstruction in the reproductive tract. So, one surgery which is well known, that is vasectomy, where you cut the vasectomy for family planning. I mean, you cut the vas for family planning. So, obviously, there will be induced obstruction or iatrogenic obstruction because of vasectomy. There might be infection which can lead to blockage in small tubules of epididymis or the ejaculatory duct. There can be congenital absence of bilateral vas deferens, or it can be a post-surgery obstructive azoospermia where the surgery on urogenital organs, all hernia repair result in scarring leading to blockage of this tract. Now, how do you evaluate? As we said that there is absence of sperms. If there are no sperms, you centrifuge. Once you centrifuge, take the pellet for examination. If there are no presence of sperm, it is you can consider it as a azoospermia. And if it is small occasional sperms, if you see, it is called as a cryptozoospermia. Now, what hormones you will analyze after you have a azoospermia situation in under the microscope? So you will be sending FSH-LH hormone, testosterone, estradiol, and sometimes prolactin, which is not very relevant and specific investigation for azoospermia, but FSH-LH, testosterone, and estradiol. Now, what FSH will help us? It is the only endocrine test. So remember, when it comes to count, it is the only endocrine test for most of the patient having sperm count below 15 million per ml. And if it is associated with sexual dysfunction, you can go on checking LH, prolactin, and total and free testosterone. Now, TSH not directly affect the sperm count, but if there is a family history or if there is a elevated prolactin, then you definitely check for serum TSH. Now, highly elevated FSH, like in the range of 25, 30, 35, in azoospermia, it is generally seen due to seminiferous tubules failure or ongoing failure of the germinal epithelium. So, you will see patients having good count, and over the time period, the count is decreasing, and ultimately he lands up in a azoospermia, that is absence of sperm. So that is called, ongoing failure of germinal epithelium. You will see highly elevated FSH. In elevated FSH as well as LH, it suggestive of testicular failure, either acquired or possibly Klinefelter syndrome is most common when you have both the elevated FSH and LH. When you have very low FSH and LH, generally seen in pituitary pathology, that is a central defect, or it can be congenital, that is happens in Kalman syndrome, which is a receptor level defect, and you will see the very low FSH and LH. So low FSH and LH both, The primary pathology is might be in pituitary or it might be Kalman syndrome. Now, if there is a azoospermia and a normal FSH, one of the reason is obstructive azoospermia, and that's why we have to see. So, sometimes the obstruction may not be complete. So you may see some numbers of sperms because it is not a complete absorption, a complete obstruction. So sometimes you do see a patient who is having very low sperm count, like less than 1 million or occasional sperms, but you may have a obstructive azoospermia. But because of that partial obstruction, you don't see lots of count, which is actually testis is normal in producing the spermatozoa. Now, normal FSH with low ejaculate volume. So you have a good count, but very low ejaculate. Sometimes patients do come with having volume of only 0.5 ml or 1 ml, but their FSH is normal. So possible indication that obstruction at the level of ejaculatory duct or a vas deferens, where you will see low ejaculate volume because of large content of seminal plasma or the semen comes from seminal vesicles. Now, if you look at the evaluation of azoospermia, so when you see azoospermia patient, you send the FSH and LH. If both are low, it is hypo, that is hypogonadotropic hypogonadism. If the normal FSH and LH, usually it is eugonadotropic hypogonadism, and it is purely because of obstructive azoospermia. Third, if you have a high FSH, but you may have a high LH or you may have a normal LH, it is hypergonadotropic hypogonadism and non-obstructive azoospermia. Sorry, non-obstructive azoospermia can be labeled. So whenever you see azoospermic patient, you check for FSH-LH, and this is how you can quickly divide the patient and point out the etiology, and accordingly you can proceed. Let's understand about hypogonadotropic hypogonadism. So this is the only scenario where a medical therapy will give you wonderful results. I mean, a patient who's got hypogonadotropic hypogonadism azoospermia, you give them medical therapy and you will see after 3 months that fantastic normal uh, regain of normal sperm count into the semen. So typically you will see FSH and LH values below 2 MIU in these patients. And this patient, you can give clomiphene citrate as 25 milligram per day for at least 74 days. You may use tamoxifen in a dose of 10 to 20 milligram per day for at least 74 days. That's a normal spermatogenesis cycle. You may take a help of anti-estrogen like letrozole, which is aromatase inhibitor. So it stops conversion of testosterone to estrogen, and that's why the anti-estrogenic effect is there. But letrozole is something which is to be measured into particular phenotype patient, and that is obese men, that is those who are very obese or overweight. And if you check their testosterone and estrogen ratio, so that this ratio, that is testosterone to estrogen ratio, if it is low, then that suggests of high aromatase activity, because those patients are having very high estrogen production because of the excessive fat in their body, and there is a low testosterone. So what you do is you give aromatase inhibitors, so it blocks the conversion of testosterone to estrogen. So estrogen production falls with letrozole and testosterone production increases. You can give 2.5 milligram daily orally for at least 74 days. That is the most important message about letrozole. So letrozole you just can't give for all the hypogonadotropic hypogonadism patient. Your particular phenotype is very important because of its main mechanism of action, because sometimes you may not see, if the ratios are normal, you may not see any impact of letrozole on improving the sperm count. This is one of the best therapies I feel ever for hypogonadism, and you give gonadotropins directly because they are available in an injectable form. So here, what you need to look is towards the FSH and LH levels. So if there are two schools of thought, that you may give directly recombinant FSH in a doses of 100 to 150 IU daily for at least 3 months, but it becomes a very expensive affair. So you can use HMG. Generally, HMG is used in a 150 IU, and you have to use it for 3 times a week for at least 2.5 months. That is That comes to somewhere around 12 weeks time period. So you generally use, though it is written here 37.5 to 75 IU, but generally you need 150 IU of HMG. You have to give 3 times in a week, and you have to give every week continuously. Such kind of at least 8 weeks you have to give, and then you can check the semen analysis for presence of sperm. You can even assess the response to this gonadotropins level by checking serum testosterone at the end of 1 or 2 months. Because if with this your LH hormones are stimulated, sorry, LH receptors are stimulated, so people, I mean, the patient produces more testosterone. So if the testosterone levels are improving, continue for भाग्यश्री को देना चाहिए फोन अटेंड करो. Then you can continue for another 1 month, and you will see that the sperms are produced because of this. Sometimes in a patient who has a very low LH, okay, patient who has got a low FSH and low LH, so sometimes you have to sensitize these seminiferous tubules with testosterone. So here in this group of patient, you will give SCG 1500 IU 3 times a day for first 2.5 months. Once you have a good testosterone production, then you add HMG, and that will also, because for normal spermatogenesis also you need a good testosterone levels. So even with a low LH and low FSH level, better to give STG first, and then you can give HMG after the STG course is completed. So that's how you can give a medical therapy. Now, non-obstructive azoospermia, where probably there is no obstruction, but there is still azoospermia. And that's commonly, we have already discussed about this, that when the testosterone to estrogen ratio, now that value is important, that if it is less than 10, testosterone to estrogen ratio, if it is less than 10, and if you check the testosterone level, if it is below 330 nanogram per deciliter, these patients will show you response with letrozole. You just give daily 2.5 milligram letrozole. This study clearly says that comparing the serum testosterone levels, testosterone to estrogen ratio, sperm count, all increases after therapy with letrozole if you select the patients correctly. Even in oligospermic patient, coming from this same phenotype, that is high testosterone to estrogen ratio, they have shown that the sperm count still further increases. It increases to such extent where you can offer IUI treatment into these patients. Though the pregnancy rates are not going to be the same, they might be little lower in comparison with normospermia. But I think this study has clearly shows that pre-treatment it was 8 million, it rise to 17 million. We know that how big difference it will make in selecting or converting this patient back to IUI. And that's why in oligospermic main, having obesity, check the testosterone estrogen ratio. It will help you to decide medical therapy. In azoospermia patient, it has been seen that you will see some amount of certain number of sperms, that is 1 million or even 1.1 million after the therapy. But that also sufficient, because you are getting now sperms from ejaculate in azoospermic patient. I think that is very, very wonderful. So check the levels properly, select your patients properly, and it will give you a better results. So, whenever you see a non-obstructive azoospermia patient, measurement of testosterone and estradiol levels in the serum are something which I always recommend. So, if they are normal, so there is no need of any medical treatment like letrozole specifically. If it is abnormal, then check for the variations. So, the one variation where the testosterone is less than 300 nanogram and the ratio is less than 10, then here again the letrozole is the first choice. And if the testosterone are really low, like less than 300, then you can give recombinant SCG 250 microgram, because SCG mimics LH and it acts on LH receptor, so it helps estrogen testosterone production. And that's why you can, if the testosterone levels are below 300 in this patient, you must give letrozole to this patient. If the testosterone is less than 300, which is a second scenario, and testosterone estrogen ratio is more than 10, then first what you do is increase testosterone by giving recombinant HCG 250 micrograms subcutaneously, twice or thrice in a week. and you check the levels of FSH, testosterone, and E2 levels at a monthly basis. So once you see a adequate increment into the doses, into the levels, you can continue the therapy and repeat that analysis after 2 to 3 months, and probably you may see some presence of some amount of sperm into ejaculate. Now, the third scenario where testosterone to estrogen ratio is less than 10, but testosterone is high. You don't need to give SCG here. You can directly start with letrozole of 2.5 milligram OD. So, friends, this is very important because this is that group I'm talking about, which is obese and having testosterone to estrogen ratio, which is above 10. So, these variations you will see according to the testosterone levels and this TE ratio. Just quickly to summarize ourselves, what and how we can handle these patients. So if you have a azoospermic patient and semen analysis shows fructose positive, so next thing you will do is a physical examination and FSH level. So if there is a primary testicular failure, which will, you will see very high FSH levels and very small testes. I mean, testes have never grown up to the size. They are very small and very high levels of FSH. That's a primary testicular failure. Probably you may have to think about donor insemination rather than going for any kind of intervention in this test. Now, going to the obstructive azoospermia, you check for the fructose whether it is absent. But if there is a low volume and a fructose absent, quite likely the vasa aplasia or ejaculatory duct obstruction. But if the fructose is present and a normal semen volume, it is obstructive azoospermia still, but it might be another reason which is called primary testicular failure. So you have to think of two. If there is a normal volume and fructose present, then it can be obstructive, it can be testicular failure. Now, if you have azoospermia, fructose negative and low volume, so obviously this is clearly obstructive, less likely distal obstruction. So you have to palpate the vas. If the vas is palpable, then it is ejaculatory duct obstruction because obstruction is beyond the vas. But if vas is not palpable, there is a high possibility of congenital bilateral absence of vas deferens, and you have to screen this husband before you do any TISA or PISA, because here you have to screen for cystic fibrosis. If it is positive for cystic fibrosis mutation, then you have to also check wife's cystic fibrosis carrier status. If she is negative, we can go ahead with the PISA ICSI with PGD. Now, if it is negative for cystic fibrosis mutation, then no need to do any screening. You can safely go with PISA and do the ICSI with the sperms retrieved from PISA. Now, if you have a azoospermia having fructose negative and low volume and vas is palpable, there might be possibility of ejaculatory duct obstruction, which we have seen. So what you will do in this scenario, when you have a ejaculatory duct obstruction, so you ask for a transrectal ultrasound study that is called TRUS, TRUS. When you see dilated seminal vesicles, it has to be obstruction at the ejaculatory ducts. If it is non-dilated seminal vesicle, it is a non-operable fibrous block, and PISA and ICSI will help you rather than doing any reconstructive surgery. So this is how you can take a help of parameters and decide which treatment to offer. Suppose you have azoospermia and having fructose positive and normal volume, and when you have done a physical examination and FSH, so if you suspect obstructive azoospermia, you go for fine needle aspiration. If the sperms you retrieve, so that is by a PISA, means sperms are present, you can do a PISA and ICSI, or you can go for microsurgical repair, that is vas epididymal anastomosis. But on fine needle aspiration, if you don't find a sperm in obstructive azoospermia, less likely you are going to get anything. This patient may go for donor insemination or adoption. So with this kind of algorithms, it has become very simplified that how we can help, take a help of assessment parameters to find out which patient will give us sperms after retrieval. So third part of and last part of my presentation is yeah, when it comes to evaluation of male infertility, and that is sperm DFI. And I think it is one of the most important investigation nowadays of our list of investigation. So what it does is that it measures the quality of sperm as a DNA package carrier, and damage to this DNA leads to fragmentation of those alleles and denaturation of proteins. So if you select such sperms having DNA damage, it is associated with a lower pregnancy success rate. It increases the miscarriage rate, and it creates chromosomal abnormalities, genetic or birth defects in offsprings. And that's why it is important that even pregnancy outcomes get affected. And that's why DNA damage assessment is increasing day by day in our practice. But a very simple technology of ICSI can overcome these barriers of natural selection, and successful fertilization after ICSI instead of poor semen analysis or sperm DNA damage. Questions regarding the clinical value of HDF testing is still on. Now, as you see this, double helix structure. So if you have single strand break, you will see it like this. And if you have a double strand break, then you will have both the strands are broken. And all these can lead to different outcomes, like there might be a DNA repair and the cell is performing fine, or may the cell cycle arrest, or it may go to degeneration due to apoptosis, and there might not be any repair, and that all DNA strands breaking leads to de novo mutations because there is no repair mechanism. Where do we do a sperm DNA assess fragmentation index? And the advanced age of the man, that is more than 40 years, obesity, having habits like smoking, cannabis smoking, chronic alcoholism, tobacco addiction. So these three habits are worst. You will see high DFI into prolonged abstinence too. So that's why it is important of abstinence before you assess the sperm analysis is can be checked that whether husband has got a prolonged abstinence, because that will lead to high sperm DNA damage. As I said, diabetes is one of the very common reason for high DFI. So please ask for that leading history questions. Check for varicocele by color Doppler. Check for infections by maybe simple analysis and checking the leukocyte count or doing a semen culture. Post-testicular oxidative stress and certain environmental toxins and occupational exposure, chemotherapy, radiotherapy will cause sperm DNA damage. These are the different causes. It has shown that if a patient is having a regular smoker, the sperm DFI is quite high in comparison with non-smoker. It also showed that the sperm DFI in a non-smoker was significantly lower than that of e-cigarettes or regular e-cigarette smoker. So e-cigarette could be a factor more affecting sperm DFI than regular cigarettes, and that is something cannot be considered as an alternative to regular smoking. And this we have to make our students and young generation to understand, because that is what is propagated, that having e-cigarette will reduce nicotine consumption. Please, it is not like that. It is very important to refrain from the e-cigarettes. Now, age also affects, like what you see in this age group, like till 40 years, the sperm DFI is seen around 11%. But we know the cutoff is 15%. So as the man goes beyond 40 years up to 50 years, 16%, 0.6% is the sperm DFI. And if it is more than 50 years, it is almost age-related DFI is 23.5%. Just a minute. Why it is not going? Okay. Now, I need not go into these all details, that what are those tests which are available in India, that is direct test and indirect test. What you remember from indirect test, which is most commonly available here, and that is sperm chromatin density assay, that is SCD assays. So here I'll quickly go to that slide particular, because that's what we follow in India, and most easy technique to so this is SCD or halo test. The principle is very simple, that the sperm which undergoes the processing while of processing of sperm DFI assessment, so it, because there is a protein denaturation and because of the staining, you will see the halo around the sperm nucleus. If you see a intact halo, that indicates there is a that's a normal sperm. But if there is an absence of halo around the sperm head, then that is a damaged sperm. So this is simply way you can test. So you can assess it a slide on which you have to prepare slides from the cement drop and undergoes all these 3 hours processing time. And at the end of it, you have to assess the slide for 400 sperms, and you have to count how many number of percentage of sperms are showing absence of halo, and that percentage is going to be your sperm DFI. So this is how it is clearly shown. These are actual pictures on the slide. So this is a good DNA. Then first picture on the left, but this is another sperm having no halo. It's a damaged DNA sperm. So this is so easily you will be able to predict it. So sperm DFI is not a very difficult test. But it has seen that if the sperm DFI is very high, natural fecundity goes down. If it is more than 30%, the pregnancy rates and delivery rates are significantly lower in treatment like IUI. If it is conventional IVF, again, DFI lower than 20% only was associated with higher clinical pregnancy rate. So ICSI is something which we have to understand is the solution for these cycles. So if we wanted to know estimation of sperm DNA fragmentation index in ICSI cycles, does it affect the outcome? So what you can see it here, the pregnancy rate in particularly in group A, that was very, very low in comparison with group B, who was got group B are the one who has got very less sperm DFI. So yes, pregnancy rates get affected and implantation rates are lower. The miscarriage rate, there is no significant difference in miscarriage rate. So can this sperm chromatin damage affects pregnancy outcomes following ART? So this is the evidence that sperm nuclear and chromatin abnormalities are associated with male infertility, and they do reduce the probability of successful pregnancy following ART. And even we need to remember this chart, that excellent sperm DFI is when the DFI is less than 15%. A good or adequate sperm, I mean sperm chromatin integrity when the DFI is between 15 to 20%. It is averaged when it is 25 to 30%, but more than 30% is a poor sperm DFI or very, very low, severely low sperm DFI. So friends, with this, one important point that it's not only the DNA damage can affect implantation rate, it also affects pregnancy rate. So it has been seen that if you start doing sperm DFI and recurrent pregnancy losses, you'll see lots of patients are showing high sperm DNA damage. And it is the level of abnormal DNA fragmentation in recurrent spontaneous abortion was significantly higher than in the control group, and that's why all recurrent pregnancy loss patient also needs to be submitted for high DFI. What you will do? So these are just the molecules, but in some time in next few lectures we will understand what can be done for a high sperm DFI. But this is just a quick review that you have to ask the husband to do a lifestyle modification. He has to quit those all bad smoking and alcohol habits which are directly affecting the sperm count. He must do some exercise every day. He must do a weight loss if he's obese. He has to do some meditation and yogas. He has to avoid environmental toxins coming from the atmosphere, from the food, which is like organic farming. He has to follow. He has to follow drinking water stored in a non-plastic jars, and you have to treat if there is any infection. Give oral antioxidants therapy, which should contain vitamin C and vitamin E as an important content of the combination. If there is a grade 3 clinically palpable varicocele, only that varicocele is something which needs repair. Or you can go for different sperm selection methods like microfluidics, or you can go for you can take the sperms from TISA, and or sometimes you can take a sperm from second ejaculate. Now, just to summarize, if you see a sperm DNA fragmentation testing on SCD test, you make sure first that whether there was any adequate abstinence of 2 to 3 days. Normally for sperm DNA fragmentation, I tell my patient to just keep a abstinence of 3 days. So he ejaculates then 3 days he takes a gap, and then fourth day he comes back for semen collection. So, friends, I think if you have a high DFI, you can think of lifestyle modification, improve and try getting DFI below normal, that is 30%. Or if it is still high, you have to consider other methods of sperm selection. So, just to summarize, the semen analysis, although indispensable in the workup of infertile couple, is not a perfect diagnostic tool. Properly perform semen analysis coupled with adequate examination of a man will give you valuable information related to his organ producing semen, but it help in better understanding of the physiology of the reproductive organs and the causes of their dysfunction. The time has come for technological developments that bring robust and cost effective clinically useful sperm function tests to replace at least partially shortcomings of routine semen analysis. The next summary is that we need to understand that ICSI has offered the hope for parenthood to many men with azoospermia. In obstructive and non-obstructive azoospermia, surgical sperm retrieval like PISA or TISA are very, very successful. In obstructive azoospermia, PISA is very effective in retrieving the sperms. In non-obstructive azoospermia, TISA is the most widely used procedure to retrieve sperms from ICSI, but with recent evidence, micro-TC is reserved for situations where all other methods have failed in procuring sperms. When genetic link is suspected as the cause of azoospermia, appropriate genetic counseling and investigation should be advised. Last slide of summary. You can use letrozole as an aromatase inhibitor and blocks conversion of testosterone to estrogen. This restores the testosterone to estrogen ratio, removes the excessive negative feedback on pituitary, and restored normal FSH and spermatogenesis. So identify your patient who can respond to letrozole better. And as we discussed about sperm DNA damage, select the testing method based on patient's characteristics and goal. And we need to have a more research on better treatment or better test to assess the sperm DNA integrity. So friends, don't be discouraged. It's often the last key in the bunch that opens the lock. So it's going to be okay in the end. If it is not okay, it's not the end. So that is very statement to be followed when you are handling male infertility. You may face failures because of lots of these problems, but remember, sometime another, she is gonna get pregnant with your therapies. So stopping is not the solution. Keep doing is the solution. So thank you very much for the patient hearing, and I hope I could give justification for evaluation of male infertility. Especially, I tried focus on sperm analysis and that report, and according to report, how you should think clinically, and the sperm DFI. Probably sometime we will think about detailed ultrasound evaluation of the scrotum, what to look for, but that might be in some other time we will see. So that's all from my side.
Th- Thank you very much.
Sir, can I speak?
Yeah, yeah, please
Sir,
go ahead
okay,
and ask
Kanchan.
question.
Sir,
Yes,
indeed
Kanchan,
a
bolo.
very nice, yes, very elaborative lecture, sir. One question from me only. Sir,
Bolo na.
what to do for hyperviscous semen, which is not getting liquid? You have discussed about this. I have listened to the lecture completely. So it is not getting liquefied. You said we need to add the culture, the sperm wash media. So how
Yes.
much and
Suppose,
how long we should
yeah.
add? Can you elaborate on that?
Yeah. So now, first thing is that if the previous report is showing hyperviscosity, then you add 1 ml of sperm washing media into the container and ask him to ejaculate into the same container. So you are not allowing it
Okay.
for coagulum to form. Now, suppose instead of that also, if there is a hyperviscosity, then next thing what you need to do is a syringing method. First is very simple, that you take a pipette and aspirate the semen into the pipette and again empty the pipette. So you do at least 7 to 8 times. That also allows liquefaction to happen. Now, suppose still it is more hyperviscous, then it is suggested that you take a syringe and use needle number 18 or needle number 16, and with that needle number, you aspirate the semen sample from the container through that needle and pass it through that needle. So you break those coagulum fibers, and that also helps a lot in most of the patients without having any damage to the sperms. So these are the simplest way you can do it, that called syringing method, and that will really help you to sort it out, this hyperviscosity problem.
Okay,
Yeah.
sir.
So there are some questions in the chat box. Kundan, can you take
Yes.
that?
Yeah.
Role of testosterone in the treatment.
Yes, I think testosterone supplementation is reserved for mainly for hypogonadotropic hypogonadism patient who is having lack of testosterone. So there you can think of as a hormone replacement therapy for a general health. But probably giving testosterone to the male, probably it's not going to help for sperm production.
Okay, so when it comes to male infertility treatment, testosterone is not the solution. Then what you mentioned in your talk, that is more important than giving testosterone. Is that the answer,
Yes,
Kundan?
that's right. So you can't
Yeah.
expect that testosterone supplementation will increase the sperm count. It won't happen.
So there is another question which says, in your practice, how many times and when do you do semen culture if required?
Okay. Yes, I think it's a good question, but a recurrent semen analysis showing presence of sperm cells and it is not getting treated. I mean, the disappearance is not happening with antibiotic therapy. And if you keep seeing significant number of pus cells per high power field in couple of semen analysis, then I think semen culture is something which is advisable. Now, the simple problem with semen analysis is typical bacteria which will infect semen may not get isolated on semen culture, and that's the biggest disadvantage we have with semen culture. And that's why even if patient do have a infection, presence of infection or bacteria in seminal plasma, they may not get incubated and isolated on culture, so you may have a false negative report. And that's why semen culture is something is not to be like left and right to be used, but whenever you see significant pus cells, you treat that patients with antibiotics. And if you repeat the semen analysis, but if you still see presence of pus cells significantly, then you must go for semen culture and try to isolate the infected bacteria and get some sensitivity, antibiotic sensitivity to that bacteria. That will help.
Right. So not much of a role in infertility practice of a semen
Yes.
culture unless